Okay, I'm going to go ahead and get started. This is going to be a quick little blood bank lecture. I was going to give another lecture about expectations for rotations, but I wasn't able to finish it in time. So I'm just going to record that and then post it later. So be on the lookout for that. I'll probably post it with like a discussion so that you can watch it and then add to the discussion. Okay, so today we are going to talk about monoclonal antibody therapies. This is a relatively new topic, so I don't think that our textbook even says anything about them. So I wanted to just talk about it a little bit so that when you do your rotations and you hear these words, you're not like, I have never heard that word in my life. It would be okay if you did, but just to give you a little heads up. So what are monoclonal therapy drugs? Immunotherapy is the use of humanized monoclonal antibodies that work with the patient's own immune system to target and mark cancerous cells for destruction. It can be used to treat hematologic malignancies and solid tumors, as well as other things. There's a whole range of these drugs available. I'm just going to talk about the two that we care about in blood banking. The first one that came out was called daratumumab. It is an anti-CD38, and they first started using this for multiple myeloma treatment, but it did so well that they've actually started using it for other disorders like amyloidosis, chronic lymphocytic leukemia, recurrent acute myeloid leukemia, acute lymphoblastic leukemia, Hodgkin and non-Hodgkin lymphomas. And then I think they've started clinical trials for some autoimmune disorders like lupus. So why do we care? We care because CD38 is a transmembrane glycoprotein that is found on a lot of different cells, B cells, T cells, natural killer cells, plasma cells, and platelets and RBCs. Why it's really useful in multiple myeloma is it binds to the CD38 of plasma cells, and it prevents proliferation and induces apoptosis. The other one that is relatively new, and it is only being used in clinical trials right now. So if your hospital that you're working at is not enrolled in a clinical trial, then you would not see this drug. If you work in a reference lab and a lot of different hospitals refer workups to you, then if one of your hospitals is involved in a clinical trial, then you might get a workup for this. So anti-47 is expressed on almost all tissue and cell types, including RBCs and platelets. Its function includes cell migration, cell adhesion, and T cell function. And it is currently in clinical trials for anti-tumor therapy. So how the anti-47 works is, so CD47 is a glycoprotein that basically prevents phagocytosis. It's basically a signal that says, do not eat me. So if you give them anti-CD47, it binds to that CD47 and blocks that do not eat me signal. So it allows for the macrophages to come in and eat those cells. So in this case, we want it to eat the cancer cells. So it's pretty neat how it works. It's neat how it works, but it's not neat when you get this in your patient because it's really a pain to work with. So what does it look like in blood banking? And this is really, really important for you to just have an idea of this, because to tell a story, we had a girl that was kind of new, and she started working on a workup, and she was getting all kinds of different reactions. It wasn't really matching a particular antibody. She couldn't really rule anything out, but she couldn't figure out what the antibody was to. So right away, if you get something weird like that, you should look at their medication history. And if they're not on any monoclonal antibodies, they're not on DARA, you can look at their diagnosis. So in this case, when this happened, it was only being used for multiple myeloma. So if you see a patient that has multiple myeloma, even if the hospital's like, oh, no, they're not on DARA to MMOB, because some people say DARA, if they're on multiple myeloma, you're really thinking that this is what it is. I would suggest maybe sometimes night shift, they might not know where to look in the computer system to look at the full medication history, or they might not know who to ask. So sometimes, like if it's on a shift change, might wait for the next shift to come in and then call again and say, hey, is this patient on DARA? Can you please look? Because it's going to determine how we're going to treat this workup. So what it looks like is it's pan-reactive at IAT or AHG in all media types, so tube, gel, and solid phase. The autocontrol and the DAT varies. It could be positive or negative. It depends on when they got the dose. If they got the dose right away, everything could be super positive, or if it's been a month or two and they're it's leaving the system, then everything could be really weak. So it looks like this patient either has a warm auto that's reacting with everything or a high frequency antibody. And then in CD47, you'll get false positives seen across all phases of all media. And you'll also have ABO discrepancies that will occur in the reverse type, except for if you're type O, because you're expecting a reverse reaction. So what do we do for DARA patients? Luckily for us, CD38 is degraded by DTT. So what we do is we have some screen cells that we pre-treat with DTT. This drug is so common now that we keep DTT-treated screen cells on hand to deal with these patients. So basically, after you DTT treat the reagent cells, they will be negative for CD38, so that CD38 will not cause interference. But the thing you have to think about is DTT also destroys the kill blood group system. So if they did have a kill antibody, we would miss it. And this is an example. So all weak reactions in all the screen cells, but the autocontrol is negative. And then DTT treated cells, everything went negative. So what we do is we phenotype the patient for the K antigen, big K, or KEL1. And if they are negative, then we will give them K1 negative cells or red cells. If they are positive for big K, they're not at risk for making an antibody, so they can get any unit. Anti-47 is a little bit harder to deal with. The first two drugs that hit the market were IgG4 specific. So if you have an IgG, it could be any isotype of that IgG. It could be IgG1, it could be a mix, B2, 3, 4. Luckily, the CD47 that came out was IgG4. And luckily, there is an anti-IgG reagent that does not target IgG4. It only targets IgG1, 2, and 3. So when you know that patient is on anti-CD47, you can, because the anti-CD47, remember, will bind to all the red cells. And we don't want to catch the anti-47 because we know it's there. So what we will do is use that specific anti-IgG that does not target IgG4. So it will only catch clinically significant antibodies. It will not bind to the anti-CD47. Now, unfortunately, there have been other anti-CD47 drugs that are not IgG4 specific. So we had to figure out a way to deal with those. What people have came up with is because platelets are positive for CD47, you can absorb the anti-CD47 out of the patient's plasma by doing platelet absorptions, but there's not that many. I mean, you have to, when they're giving you these drugs, there's a huge amount present. So you have to do a lot of absorptions. Usually you don't want to do more than 4 absorptions because at that point, if there is a clinically significant antibody, it might get diluted out. So usually blood banks will have a protocol for how many absorptions they can do, and usually people stop at 4. But sometimes even after 4 absorptions, that reactivity is still present. So really the only thing we can do is genotype the patient. So if we genotype the patient, remember we can't really phenotype if the DAT is positive, because if that anti-CD38 or anti-CD47 is binding to the patient cells, that's going to block the antisera, so you can't really do phenotyping. So you want to do genotyping. And once you get the patient's phenotype, then you'll just have to find phenotype matched units to give that patient if they need blood. So it is quite a challenge, and phenotype matching units is very expensive. But if you can't do an antibody ID, then you can't safely say for sure that that patient does not have a clinically significant antibody. So then the safest way to handle it is to just give phenotype matched units. And here is a little table. It's very nice. It has basically how we would handle it, what we see, and oh, of note, so we do platelet cross matches sometimes, and you would get interference with platelet cross matches because those monoclonal antibodies would bind to the platelets and you would get a false positive. So you pretty much can't do a platelet cross match if they are on one of these drugs. You would have to do HLA matched platelets. Any questions about that? That was a really fast go through, but this is a really niche subject. If you are in like a little hospital, you probably won't deal with this. But if you're in a cancer hospital or a large hospital like Shands that deals with all kinds of things, you will definitely encounter these. So when you do your rotations, if you go to Shands or Life South, you will probably see this. If you go to North Florida, you probably, you might see it. I'm not sure. Any questions? Okay, I won't hold you guys on a Friday. So I will be posting this, and I will be posting another lecture about what to expect from your rotations and after rotations. Because I have a lot of students asking me, how do I apply for the ASCP? How do I apply for my license? How do I apply for jobs? What do I expect? So I was hoping to go over that today, but it's okay. I will record it as soon as that's ready, and I will post it. So if no one has any questions, that's all I have for today. Okay. Well, everyone have a wonderful weekend.